I want to thank all four of you. This has been a very rich and informative discussion. Before we conclude, I'd like to get your final thoughts, sort of what you're the most excited about moving forward, and sort of any pearls that you think I discussed. So Tom Krivak, I'm going to have you go next, and I'll go Sharon Lewin, Dr. Herzog, and Katie Moore will give you the last word. So Tom Krivak, what are you excited about, and what pearls do you think were brought out today?
I'm excited about the trials that you guys talked about. First trial up front, I think that Katie changed the standard of care with Solo 1, 218 changed the standard of care, and now we're looking at different combinations in upfront settings because we really wanted to try to get that PFS the longest up front. I'm really excited about, I know that we've talked about HRD, but I think that the HR proficient group's about 40 to 50% of the population. It's going to be very exciting to see what Athena may bring about with that. And it's going to be exciting to see what FIRST is going to bring about in that subgroup of the HR proficient subgroup. And I completely agree in that anybody who has recurrent ovarian cancer, the first thing that we need to do is look at our clinical trials, see what they're qualified for, because we have probably 3 or 4 competing trials open. And to me, it's about selecting patients for these trials because we're not going to get the answers unless we do that. I think there are lots of options for all these patients, and a clinical trial is tremendously important. I work at Allegheny Health Network, which is kind of a community-based center that has residents, but we're very passionate about clinical trials because we know that's what's going to change the standard of care and move that needle to improve the quality of life as well as to improve the longevity of life with women with ovarian cancer. So.
Well, thank you, Tom Krivak, for being with us. And I know you're a big time enroller, and you're a great author. You like to write things and teach things, and you're known for your clinical expertise. So, thank you for that. So Sharon, go ahead. Pearls, summary.
Pearls and summary. I mean, I agree with everything Tom said, just saying things a little differently, just to highlight again the importance of really germline testing all these patients when they're diagnosed. Also definitely I believe in HRD testing. But, we do see in a lot of these trials still women that have an upfront cytoreduction and really are completely cytoreduced even do best. So I think we shouldn't also forget the role of surgery for these newly diagnosed women as well, too. But again, clinical trials, we still have a lot of important questions to answer.
Thank you, Sharon. It's been good seeing your face and hearing your comments. Go ahead, Tom Herzog.
So Brad, thank you. It's always harder to be fourth, but it looks like I'm third, so it's still a little bit difficult. But I agree with everything that's been said. I think for me, it's important to figure out how we're going to use all the new toys that we now have available. And so while some people will let subgroup analysis guide that, I think you can rely on that to only so far, but it is helpful. And we want the science to really take us the rest of the way. Which of these subgroups really benefit from these different combinations and so forth? I do think it is about combinations. And I guess what I'm most excited about is really starting with Katie's Solo 1 and now extending and looking at the opportunity to do combinations with BEV and PARPs and so forth. Can we cure more women with frontline ovarian cancer? And to me, that's the most exciting thing that I've thought about in decades in working in this disease. So thank you for having me today.
Thanks, bud. Go ahead, Katie. I wanted to thank you for your leadership within the Society of Gynecologic Oncology. Even though it was virtual, it was still the best meeting. And we would have enjoyed going to Toronto, but we've certainly enjoyed the virtual opportunity. And with your leadership, you were able to pivot quickly to this virtual opportunity. I'm glad that we could be together virtually today. But I'm going to give you the last word and tell us sort of what the future holds in your mind and what you're the most excited about.
Thanks, Brad. And thank you again for having me. The first thing I'm going to point out, you guys kindly keep referring to Solo 1 and Quadra as my studies, but these were all big team-based efforts, many times international efforts with many dedicated investigators. And I was just fortunate enough to lead. So clinical research is a team-based effort, and we just have to keep that in mind and keep moving forward. We've sort of, I think with ESMO and what we'll see are the new indications that's sort of yet to be decided any day now, will set the new floor for ovarian cancer patients. Like, this is where we are now. and we have to sort of build off of that. And I think there's very exciting opportunities. Even though I don't love the HRD biomarker, it definitely has made us think differently about populations of patients, especially the group, if we can really identify those that are truly proficient in homologous recombination function, really studying that group and really being science-driven in how we design studies to help them live longer and better, I think is going to be sort of the next big challenge that we need to undertake. And it may not be PARP inhibitors. I think it may be something else, or it may be a combination, figuring out, is it CCNE1, what, cyclin E1, I'm sorry, how do we target that group of patients? That's sort of what I'm interested in. And we're already designing studies for that population. And I'm excited to be involved in those. I'm anxious to see what the FDA indications are, and I'm excited to have, at least I know, expanded options for women with ovarian cancer in the front line. And I do hope it translates to a higher percentage of the cure fraction. The patients in SOLO-1 are doing so well that we will not have that answer for a long time, and that's a good problem to have. But PRIMA is a much higher risk population. PAOLA is a much higher risk population, so we may get signals from there earlier. And I think that's important. So it's an exciting time, but I think we have to pivot our focus a little bit and really start looking at smaller groups of women within the ovarian cancer diagnosis to really make big improvements, because it's going to be hard to do even in the HRD group. I think we're just identifying all the subgroups that we have to study probably differently. It's like 8 rare tumors.
So I want to thank all 4 of you, Tom Krivak, Tom Herzog, Sharon Lewin, and Katie Moore. Thank you for your friendship. Thank you for what you do for your patients and how you teach us, based on the clinical trials and your personal experience, how to take care of our patients. So I hope the audience found this interesting and informative. I look forward to the next time that we're together, and so long for now.